Thank you for taking the time to view this presentation. And I would also like to thank the organisers for inviting me to speak on this topic. What I want to do is talk about two of the main points, the main conclusions from this forthcoming ICRP report. Publication 147 should be available very soon. I've listed here the membership of the task group that produced the report, which, as you can see, includes membership from across the 4 committees of ICRP, and also in the person of Hans Menzel from ICRU as well as ICRP. So I want to talk about the 2 points shown in red. I'll read these. So we start with this one. Absorbed dose rather than equivalent dose is the appropriate quantity for use in setting limits on organ tissue doses to prevent tissue reactions, deterministic effects, rather than the current use of equivalent dose. And then lastly, on this selection of main points from the report, effective dose can be used as an approximate indicator of possible risk, recognising that lifetime cancer risks vary with age at exposure, sex and population group. So we go back to basics. We need dose quantities to set limits to prevent tissue reactions, and also dose quantities for the control, optimization of protection against stochastic effects, for which we assume a linear non-threshold dose-response relationship, LNT. And what we have are these 3 quantities: absorbed dose, equivalent dose and effective dose. So absorbed dose is averaged energy deposition across an organ or tissue or small region within a tissue. So measured in joules per kilogram and given the special unit Gray. The next quantity here, equivalent dose, is calculated from absorbed dose, but again to organs and tissues of the body, adjusted using radiation weighting factors to take account of the different effectiveness of different radiations in causing stochastic effects, principally cancer. And then effective dose is the sum of the equivalent doses, is single quantity, is sum of the equivalent doses, weighting each of these by a tissue weighting factor, which represents its contribution to overall stochastic risk. So correctly, effective dose is a weighted average of organ tissue doses, and you can see that there's 2 sets of weighting factors involved in this calculation. If we look at the radiation weighting factors that are used in the calculation of equivalent dose, they're based on RBE measurements, experimental data with some direct epidemiological comparisons, limited information supporting the experimental data. So the effect of a test radiation compared with a reference low LET radiation, mainly gamma. And I've shown the example here. So the radiation weighting factor for alpha particles used in the calculation equivalent dose is 20, compared with a value of 1 for gamma rays. And the focus in the choice of radiation weighting factors, WR values, is RBE data for stochastic effects, like cancer-related endpoints, rather than endpoints relating to tissue reactions, cell killing. And in general, values for stochastic related endpoints are substantially higher than those for relating to tissue reactions. And in the example given here of alpha particles, whereas the WR is 20, values relating to tissue reactions generally substantially lower, perhaps in the range of something like 2 to 5. Now, currently, limits to prevent tissue reactions are set in equivalent dose, although as we've just briefly touched on, the WR values used in the calculation of equivalent dose relate to stochastic effects, not tissue reactions. So one of the important conclusions in publication 147, this forthcoming ICRP report, is to discontinue this use of equivalent dose as a separate protection quantity and use absorbed dose in grey to set limits to prevent tissue reactions. This will mean then that we have consideration of organ tissue doses in grey, and then consideration of stochastic effects using effective dose in sieverts. This change will parallel the proposed changes in operational quantities that Hans Menzel has spoken about, and the intention is that the changes would be introduced at the time of new general ICRP recommendations, so they would be set out again in the new general recommendations and introduced after in the implementation of the new general recommendations. And then lastly on this list, there would then be the need to look at radiation weighting for tissue reactions and specify values for these endpoints, as well as looking again at the values used for stochastic effects. Okay, so moving on to effective dose. Effective dose relates to what's called detriment, stochastic detriment. The starting point in the calculation of detriment is cancer incidence data, mainly from follow-up studies of the A-bomb survivors, Hiroshima and Nagasaki. And what this slide shows in these first steps is the adjustments made, first of all to lower dose and dose rate, and then to apply these risk estimates across different populations so that they can be averaged to apply to an averaged world population, and then adjustments for lethality, quality of life, years of life lost from these incidence values, a small addition to take account of heritable effects, and then you can see the totals here of around 4% per sievert for a working age population, near to 6% per sievert for the whole population. And ICRP also says in publication 103, the 2007 recommendations, that this approximates 5% per sievert when we're talking about fatal cancer risk. Yes, and this just shows the contribution of individual organs and tissues to the overall detriment for the population averaged value. So that's the around 6% per CVET there, and you can see the different contributions, and then expressed in terms of relative detriment here. This then shows the tissue weighting factors that are based on the relative detriment values, just to really show you that these are very much simplified, rounded values. Yeah, and another factor to take into account in looking at the calculation of effective dose is sex averaging. So we now have this family of anthropomorphic phantoms, males and females of different ages, and so organ absorbed doses and equivalent doses are calculated separately for males and females of different ages, and then averaged in the calculation of effective dose. And ICRP uses this methodology to calculate extensive sets of effective dose coefficients for intakes by internal intakes of radionuclides into the body, the internal exposures, and also external exposures of workers, members of the public of different ages, and medical patients. So what about this point about effective dose and risk? Why do people worry about this equivalence and using effective dose as a measure of risk? Well, we should start with this first point. For the use of effective dose, we need to assume an LNT dose-response relationship. We need to assume that chronic exposures, for example, from internally deposited radionuclides, are equivalent to acute exposures, and that internal dose is equivalent to doses from external exposures. The evidence for each of these is really quite reasonable and increasing, and of course these assumptions apply to all use of dose and risk estimation, and not just to the use of effective dose and its relationship with stochastic detriment. The second point on the list, we are using simplified radiation and tissue weighting factors in the calculation of effective dose. This is certainly true, so we recognise this as a simplification. Effective dose is applied to a sex average reference person, as we've just seen. So this is a point when we know that there are differences in risk between males and females. And it relates to population average detriment when we know there are also differences in risk as a function of age and exposure. To come on to both of these points in a second. And lastly on this list, no consideration of uncertainties. So when we use effective dose within the protection system, or we don't explicitly concern ourselves with uncertainties, although it's often helpful to have an understanding of the uncertainties in a dose assessment. Yeah, so this just shows an example of differences in risk as a function of agent exposure and the difference between males and females, expressed in terms of lifetime cancer incidence for a Euro-American population, but it could equally be done for the world average population as used by ICRP. So for a range of organ tissues and different cancer types, we see that overall the risk is greatest for exposure at the youngest ages, and somewhat greater in females than in males. But these differences, as you can see, are quantifiable. So we're talking about approximate doubling, a factor of 2 to 3 increase at the youngest ages, and then falling off to low values at older ages. And it's in medical applications that some idea of the risk associated with a measure of dose, and quite often its effective dose, is important. So a clinician may well want to know when he's planning to use a diagnostic procedure, for example, just have an idea of what the risk associated with the dose given will be, for his own understanding, and also for potential communication with patients. So it's often quite a simple understanding of that risk that's required, and so this is a table that we included in the forthcoming ICRP publication 147, which categorizes different medical diagnostic X-ray procedures, examinations, in terms of the dose level. So starting at the top here, if we're talking about, say, multiple CT exams, and we're up into the hundreds of millisieverts, then we have direct epidemiological observation of risk at these levels. And for this specific application, we're terming that a moderate dose, or moderate risk. And then going down by orders of magnitude. So we have some evidence of direct evidence of risk in this band here, but by and large we're inferring risks on the basis of LNT for these different lower bands. And you can see the terms that we've used in association with these different bands for this particular context of diagnostic X-ray examination. So low, very low, minimal. But this study goes a step further and looks quantitatively at the differences in risk for different medical X-ray examinations. So separately here for females and males, what was done was best estimates of risk were calculated using organ and tissue doses and agent sex specific risk factors, and then expressed per effective dose from the different procedures. And you can see this fall off in risk with agent exposure and somewhat higher values for females than males. And the ranges observed here are due to the different sensitivities of different organs and tissues irradiated in the different procedures. But by and large, we're talking about the same sorts of differences as we've already seen. So if we're going from around, let's say, a risk of 5% per sievert in middle age, we're going up by a factor of 2 or 3 at the youngest ages, and then down to very low levels at the older ages. So the conclusion in this ICRP publication 147 is that indeed we can use effective dose as an approximate indicator of possible risk, and particularly in the sorts of circumstances that I've mentioned. And we can go a step further and have an idea of age and sex variations, so a factor of a few higher in younger children and lower at older ages. But in doing that, if we're using any sort of numerical estimate of risk, we should recognise the uncertainties associated with such estimates, and also recognise that this use of effective dose as an approximate indicator is not a substitute for a full risk analysis using organ and tissue doses, although in many cases it will give similar answers and lead to the same conclusions. Yeah, I just wanted to say a couple of words about possible future changes. These are mentioned very briefly in publication 147. So we now have these anthropomorphic phantoms for adults, children of different ages, and we use best science in the calculation of organ doses. So why not use best science in specifying the associated risks and have different values for different well, for males and females and for different ages of exposure. So then we would specify effective dose separately for males and females of different ages, and there would be greater transparency in the recognition of differences in dose and risk when setting protection criteria and seeking to protect different groups within the population. And then lastly, on this slide, this last point, it's already the case that many people are using their own phantoms to calculate size-specific, patient-specific doses. And they're calling the result effective dose, although clearly it isn't the reference effective dose that is specified by ICRP. Nevertheless, in many cases it can serve a useful purpose, and so I think we need to look formally at advice on the use of phantom libraries to calculate doses in this way. So my last slide, I'll leave you with these two conclusions and encourage you to look at this report, publication 147, when it becomes available. The conclusion is that we should discontinue the use of equivalent dose as a protection quantity and use absorbed dose to set limits to prevent tissue reactions, and this will be done at the time, or introduced at the time, of new general recommendations. And then the second point, explicitly recognise effective dose as an approximate indicator of possible risk. So, thank you for listening.